So someone asked me, what's new in neonatal sepsis? Well, I've been thinking a lot on this, and I think the only thing new in neonatal sepsis is that we need to go back to the basics. It reminds me of something years ago when I think I was doing my house job, and for the very first time I was asked to do a presentation. The topic was fungal keratitis, so I made some of it, but then I remember I copied some of the slides from my senior, gave that presentation, and everybody praised that presentation. It went very well. And then later on I came to know that I had the slides that I had copied from my senior, he had copied it from his seniors, and that his senior had copied it from his seniors, and then they had copied from their teacher. So I laughed a lot on it, like it's been going on, and I'm waiting for that moment where, Archimedes came out of his bath and said, Eureka, I have found something new. And we're still waiting for that time, okay, when we will say, Eureka, we have found something new in neonatal sepsis. And, people, pediatricians or neonatologists would be like jumping off their bath naked and running out saying they have found something new. But I think the more advances that we had in this thing, I think the more screwed the management has become. So I think we need to go back to the basics and try to refine those things. So let's dive in and get started. So a few days ago, I was asked by one of my students that, sir, kindly make a lecture on some updates in neonatal sepsis. Give us something new about neonatal sepsis. And I was scratching my head on this one, went through the literature and was looking into some of the papers. And then as a reflection, I was thinking, like, as far as the update are concerned, like what's the new in neonatal sepsis? So I think this cartoon actually depicts the sentiment. I mean, we are still waiting for that moment, like when Archimedes in his bath, like said Eureka when he found out what used to cause buoyancy, and that was an important concept in physics, at that point in time, hundreds of years ago. So still like on the same perception, we are waiting for the time when neonatologists would one day like, jump out of their baths naked and say, Eureka, we have found something new. And the new is like, I mean, the more that we are having advances in the field of neonatology, neonatal medicine, we are seeing that the things have been screwed up. So I think the new here is the time to reflect back on the practices, go back to the very basic, and set the things quite straight for us. I mean, it's quite simple. We still need to go back to the very basics, which were probably a decade or 2 decades back. They were the same things, but we need to follow them in letter and spirit. So to start with, I mean, neonatal sepsis, I mean, you should remember in very simple words, it is the presence of invasive bacterial infection in a neonate. So if a neonate has got bacteria thriving in his blood, it could be just like urine, it could be any part of it, but for most of the times we take it as invasive bacterial infection simply means the presence of bacteremia, the presence of bacterial growth in the blood, which is actually proven by the blood cultures. Nevertheless, I mean, if bacteria are present, we call it as neonatal sepsis. And very simple classification is that we divide them into two. One is the early onset neonatal sepsis, and the other one is the late onset neonatal sepsis. Very simple. The early onset is within the 72 hours of birth, and after that, if a neonate has got sepsis, we call it as late onset neonatal sepsis. And again, there are major differences between the two. Early onset neonatal sepsis is mostly because of vertical transmission from the mother to the neonate, while the late onset neonatal sepsis is caused by horizontal transmission, and that is because of the environmental factors, like, for example, bad hygiene, being coming into contact with contaminated surfaces or clothes or contaminated environment, to be very simple. While the early onset neonatal sepsis, which is caused by vertical transmission, is usually occurs because of maternal and fetal risk factors. So in most of the cases, there would be either a presence of maternal risk factors or fetal risk factors or both of them. Like, for example, prolonged labor, premature rupture of membranes, prolonged rupture of membranes, colonization of the maternal birth canal by group B streptococci, or fetal sort of stress because of let's say placental factors or vascular factors inside the mother. So there is like a host of different factors which would become the risk factors, and actually they predispose the newborn to develop invasive bacterial infection within the first 72 hours of his life. Now, of all these things, remember the only one which is really considered to be a risk factor throughout consistently in all the papers is number one, chorioamnionitis and fetal age. So these are the two consistent and major risk factors. The other risk factors, well, again, for most of the risk factors, we do cover them with antibiotics and things, but the only one thing which has been consistently shown to increase mortality or has been, really associated with neonatal sepsis is number one, presence of infection in the membranes, which is known as chorioamnionitis, or number two is the fetal age. So fetal age, in other words, means like prematurity or post-maturity. So prematurity and post-maturity both increase the risk of neonatal sepsis, while a child who is term, like anywhere between 37 to 40, 41 weeks, the risk is minimum, and this has been consistently shown by different studies. But before that, like if you go, the more premature the baby is, the higher the risk of developing early onset neonatal sepsis. Similarly, a child who is post-dated or like say birth after 41, 42 weeks, then they are also at increased risk of neonatal sepsis. And some of the major pathogens that are involved in the early onset neonatal sepsis are, remember, it's very simple. They are E. coli, because E. coli is a sort of an enteral part of the enteral flora, and because of the close proximity of the anal canal to the vaginal canal, obviously colonization can occur, and the neonate can get vertical transmission at the time of birth. So E. coli is one of them. The other is group B streptococci. In certain, like women, there could be colonization of the birth canal with group B streptococci, and the child can get it. Though this is part of the normal commensals in the pregnant women, but obviously a child, because of his weak immunity, can get an invasive group B streptococcal infection and develop neonatal sepsis. Listeria is another rare cause of early onset neonatal sepsis, and rarely, if the mother has got like genital herpes, then obviously a child can get herpes sepsis as well. And but anyhow, that's rare these days. Late onset neonatal sepsis, which occurs 72 hours after the birth, is usually caused by environmental risk factors. So obviously, if the child is admitted in the hospital for one reason or the other, and he develops late onset neonatal sepsis in the hospital, that is usually because of resistant bacteria, and the common bacteria that cause hospital-acquired late-onset neonatal sepsis are Klebsiella and Pseudomonas, and they're quite resistant. So sometimes we have to use like for, if culture usually fourth generation cephalosporins are also started in certain settings. But nevertheless, it depends on the antibiotic sensitivity, which is different from in different geographical regions of the world. Apart from these hospital-acquired Klebsiella and Pseudomonas, the other environmental bacteria which can cause community-acquired late-onset neonatal sepsis are pneumococci. It could be staphylococci. Again, E. coli is also involved in these cases, and sometimes Haemophilus influenzae can also be implicated in late-onset and neonatal sepsis. So, for simple reasons, two types: early onset, late onset. 72 hours is the cutoff. Before that is early onset. After that is late onset. One is because of vertical transmission, the other is because of horizontal transmission, and I told you about the different types of pathogens which are involved in this process. Moving on. So let's talk about the presenting features, because in neonates, this is, it begins with a very subtle presentation. So again, there have been various studies that have been done as far as the presenting features of early as well as late onset neonatal sepsis are concerned. And number one, the one which has been consistently shown in most of the studies, is that the very first symptom, the most common early symptom, is decreased activity of the baby. So usually the first symptom that would be reported is the child is less active. The child is sleeping most of the time. He's off feed. He's not taking his feeds. So he's refusing feeds, or he's not interested in feeds, or the feeds have gone down without any obvious reason, or the child is less active. He's not making that movement. He's sleeping most of the time, or the child is floppy. He's hypertonic. He hasn't got, he's very limp. Or they can also develop cold extremities and cold central part as well. We call it hypothermia. So the temperature is less than 35.9. Obviously, that goes within the what the zone of hypothermia, and that could be one of the early uh, features of neonatal sepsis. Again, color changes. If the baby becomes off colors, becomes mottled, and I think that could be another one of the earlier signs of neonatal sepsis. Now, these the symptoms are very non-specific. That doesn't mean that if you find these symptoms, you should start thinking of neonatal sepsis. But this could be, as I said, neonatal sepsis could be one of the reasons for these things. So there are other common reasons for a child being off feeds or for hypotonic and hypothermic. But again, depending on the circumstances, you can think of neonatal sepsis as well. The late features or the less common features are usually a child can have apneic spells, frequent apneic spells who will stop breathing, followed by bradycardia. They can have temperature. So if the temperature is greater than or equal to or greater than 38 degrees Celsius, obviously that warrants neonatal sepsis screening and workup as well. They can have tachycardia and tachypnea that could be associated with fever, or that could be without fever as well. Rather, if it is without fever, one should be worried because one needs to find out what is the reason for that. Obviously, there could be other reasons for that as well, like for example, sometimes the congenital heart disease can be responsible for that. Nevertheless, you should keep sepsis on the top of your head. Then irritability. So that's the opposite. A child can, in the early phases, can be very much sleepy, but in the later stages or less common, could be very irritable, who's crying, who's not settling down, and is very whingy. That could also be one of the symptoms of neonatal sepsis. And sometimes the child can be very pale, though this is less common and usually seen in and it's seen in late stages of sepsis. So the thing is, if let's say based on the symptomatology, if we are thinking sepsis, then what to do? Obviously, the best diagnostic test for neonatal sepsis is culture. So you have to have a blood culture, or you have to have a urine culture or CSF culture, which proves the presence of bacteria within these body fluids. But before that, we need to apply the screening criteria. And the screening criterion or neonatal sepsis screen is when you take a small sample of blood and you look for five things. So if any two of the following five things are positive, we call it septic screen positive, and then it requires further workup, which includes blood culture, which might include chest x-ray, which might include urine culture, which might include lumbar puncture and CSF examination. So the white blood cell counts. The first thing is white blood cells. So if the white blood cell count is less than 5,000, the white blood cell count changes on a daily basis. So there are nomograms which are used for that. So anyhow, white blood cell count less than 5,000. Remember, it's rare that the white blood cell count would go high in case of neonatal sepsis, because in any case, white blood cell count is quite high in neonates. So if it is less than 5,000, one should, it's more like, sort of a specific for neonatal sepsis rather than an increase in white blood cell. So remember, it's the decrease in white blood cell that we are more worried about rather than the increase in white blood cell. Though increase in white blood cell can also happen, but it's more so the decrease in white blood cell that we would be worried about. So if the white blood cell count is less than 5,000, or the absolute neutrophil count is less than 1800 per cubic millimeter, or the IT ratio. This is the ratio of the immature cells to mature neutrophils. So again, when you are examining or the lab is examining the blood film, so they are looking at the mature neutrophils as well, or the mature white blood cell and the immature. So this is also known as bandemia. So if it is greater than 0.2 or 20%, so if more than 20% of the cells are immature, we call it bandemia. More than 20%, that is also sort of a criteria for a positive neonatal sepsis screen. Or the micro ESR. So micro ESR, we take a very small capillary tube and we keep it for 1 hour, and if that is greater than 15 millimeter at end of first hour, at end of first hour, if it is greater than 15, it is positive, or the CRP is greater than 1 milligram per deciliter. This is deciliter, not liter, deciliter. So if any two of the five, so there are five, but if any two, like these two, or this plus this, or this, if any two are positive, then it is sepsis is possible in that case, and that requires a further workup. So that further workup would mean that you have to do blood cultures, you have to do urine culture, you have to do chest X-ray, you might have to do cranial ultrasound, and you might have to do lumbar puncture with CSF examination, and again gram staining and culture, etc., etc. There are different types of things that can be done on CSF. So this is the screening criteria. So if two or more are positive, then you will move on to doing these things. But also keep it in mind that this is very high then. This criteria has got a very high sensitivity with a high negative predictive value. Again, this is an exam thing as well. They might ask you, is it specific or sensitive? So it's got very high sensitivity. So there would be very few false negative. Like somebody who has got normal white blood cell count and absolute neutrophil count and IT ratio and micro ESR or CRP is normal, then it is almost like you can safely rule it out. So a high sensitivity means that it has got a very high negative predictive value. In other words, if it is negative, you can swear that the child hasn't got neonatal sepsis. But if it is positive, it has got a very poor specificity. So it's not only if it is positive, it could be because of sepsis, but that doesn't mean that sepsis is the only cause of increase in these. There could be other like different reasons for increase in white blood, decrease in white blood cell count, or decrease in absolute neutrophil count, and again increase in micro ESR or CRP. So it has, if it is negative, then you can rule it out safely. But if it is positive, you cannot be sure about sepsis. That's why we need to do a lot of other works like chest X-ray, like urine culture, like blood culture, like CSF culture. So that has to be done in order to diagnose neonatal sepsis, because again, as I told you, this has got very poor specificity. It's only got high sensitivity, which means it has got very high negative predictive value, and this is an exam point as well. So this you should remember very, very, very well. Now, as far as CRP is concerned, there's a bit of debate about CRP as well. One CRP value does not give you much because CRP rises in 6 to 12 hours after infection. So it takes at least 6 hours of infection to make a rise in CRP, and then it gradually rises. So sometimes we say that serial CRP is more helpful rather than one value, because one value can be normal as well. So you have to have a serial CRP levels on every day, and if you see that the CRP is raising, that is more sort of a specific for neonatal sepsis rather than having one. Procalcitonin is done these days. This is a precursor of calcitonin, and this rises in the first 3 to 4 hours. So it rises even before the CRP rises. So procalcitonin, like if the value is greater than 5 microgram, that is very sensitive for neonatal sepsis. It is more sensitive than CRP, and in many settings, procalcitonin is done as a part of the neonatal sepsis screen along with CRP, because it is more sensitive and more specific for bacterial infection. So this you should also remember, that procalcitonin is better than CRP. Why? Because procalcitonin rises in the first 3 to 4 hours as compared to CRP, which takes at least 6 to 12 hours to rise. So this thing you should be very crystal clear about. Then as far as the blood cultures are concerned, again, we have seen in practice that the yield of blood culture is quite low, especially in developing countries. Many times, like the blood cultures comes out to be negative. And there is a reason for that. We need to have at least 1 mil. 2 mils of blood is ideal, like to have, if you're sending it for blood culture. But I've seen, like, in majority of the developing countries, even in developed countries, like because again, it's a bit hard to take blood from the neonate. So usually zero point 0.5 mils of blood is taken for blood culture, and usually in that case the yield is quite low. So the yield is not more than 55% if you take zero point 0.5 mils of blood. But if you take 1 mil, that increases to 70%, and if you take 2 mils, then it increases to 85%. So that's why it is ideal that you take a little bit more amount of blood if you want to send for blood culture. So 1 mil is ideal. 2 mil is actually ideal, but 1 mil is like what we recommend. But nevertheless, I mean, the zero point 0.5 mil would give you a low diagnostic yield for blood culture. That's why most of the blood cultures, they come out negative, and most of the antibiotics are still continued with negative blood culture based on clinical suspicions. And that clinical suspicion is simply because the yield is quite low. And I gave you the reason why the yield is low. It's simply because low amount of blood is used for blood culture. Now, as far as the treatment of neonatal sepsis is concerned, again, both early onset or late onset. The thing is, because if you are suspecting sepsis and if you've got a strong suspicion, you have to start antibiotics. So remember, you cannot delay the treatment. And again, the problem here is that we need blood culture to diagnose that. Now, blood culture takes at least, like the initial report takes at least 2 to 3 days to come, and then sensitivity might take even longer. So we take the bloods and we start them on empirical therapy. Now, empirical therapy for early onset neonatal sepsis, again, different books use different regimes. Again, different countries use different regimes. Like local guidelines, they are different from trust to trust, from country to country, from geographic region to geographic region. So obviously, if where you are working, it has got its own guideline, you should adhere to that. But again, if there are no guidelines, remember the general principles of therapy remains the same. And that is, again, we have to start with empirical therapy. And empirical therapy means that we have to cover most of the gram positive and gram negative. So broad spectrum antibiotic which cause gram positive and gram negative organisms which cause early onset and late onset, that has to be covered. So the best combination, empiric combination, which is still used all over the world, is ampicillin plus gentamicin. So ampicillin plus gentamicin. In some countries, like where I work, they use amoxicillin instead of ampicillin. But remember, ampicillin and amoxicillin are closely related to one another. That doesn't make any difference. They belong to the same family. They've got like the same efficacy. It's just a little bit difference in the pharmacokinetics, but the dynamics are the same. So ampicillin plus gentamicin is intravenous. That is the best initial empirical therapy for early onset neonatal sepsis. And again, we start that ampicillin again, 100 milligram per kg body weight can start. Sometimes, like some authorities say, they can go if we, if there is meningitis, like where the CSF is positive, then even up to 200 to 300 milligram per kg body weight has also been used. Gentamicin 5 milligram per kg IV can be used, and we use it till we get the culture sensitivity report. So if the culture sensitivity reports are negative, so if we get two negative reports of 48 hours, like the cultures are negative, then we have to stop the antibiotics. Remember, we cannot go on blindly. But again, we have seen that in many settings, a neonatologist, a clinician, they still move on. They continue with antibiotics. Once they started, I mean, I've seen it's very hard to stop the antibiotics. Very difficult. Like it's easy to start, but difficult to stop. So they carry on with that. But again, as I said, the evidence tells us that if they do blood cultures are negative, like if it is cultures are negative for 48 hours, you need to stop. You need to stop the antibiotics. Or if the culture is positive, then you have to look for the report. So you have to follow the antibiotics based on the culture sensitivity report. So you, most of the time, it has to be continued for 7 to 10 days if you find it. But in meningitis, the treatment has to be continued for 3 weeks because it is associated with complications like deafness, subdural effusions, things like that. So in that case, 3 weeks is the recommended. For late onset neonatal sepsis, again, we start with ampicillin and gentamicin. And again, ampicillin can be substituted with amoxicillin. And again, this is where we are thinking of community acquired strain, because again, I told you late onset could be community acquired or hospital acquired. Now, community acquired is where most of these strains are thought to be sensitive. So if you've got local data, you would follow that. If not, then ampicillin and gentamicin are good enough where most of the strains are thought of that they would be sensitive to these antibiotics. Now, where you think that there might be some resistance that is might be possible, then in that case, we take ampicillin and we combine it with cefotoxime. So ampicillin plus cefotoxime is substituted, or amoxicillin plus cefotoxime is substituted for those conditions in which you think that there would be some of the bugs which might be resistant to some of the antibiotics. So that's why ampicillin plus cefotoxime is a third generation broad spectrum antibiotic to cover the gram negative, especially E. coli and things, that is used. If it is hospital acquired infection, like baby has been admitted for one reason or the other and he develops late onset neonatal sepsis in the hospital, then obviously we are thinking of much resistant bugs like Klebsiella, Pseudomonas. So in that case, the recommendations are that you should be using cefotoxime and you combine with amikacin. So either you give this thing or you give piperacillin tazobactam combination and you combine it with amikacin. and where you are thinking that a Staphylococcus aureus or MRSA might be responsible, then you can add Vanco to the regime as well. So these are quite expensive combinations, and obviously this is for hospital acquired late onset neonatal sepsis. So as I told you, either you go for the combination of cefotaxime plus amikacin, or you can use, especially if you are thinking of pseudomonas, then you have to add piperacillin tazobactam, because that is very effective against pseudomonas. And then you can add to it amikacin antibiotic. And where you are thinking of MRSA or staphylococci, then to this you will be adding a third drug as well, and that is vancomycin. So this is the empirical as well as the general principles of treatment of neonatal sepsis. Again, I told you, you have to follow your local guidelines, but nevertheless, if you have got no guidelines, you can just simply follow these basic principles. So the only thing new is, like, you have to go back to the basics, consolidate this basic. This is what we need. And again, as far as these empirical antibiotics are concerned, the principle is again that you have to, these are empirical, so you have to use it till you get your blood cultures reports. So if your blood cultures reports are negative 48 hours, you stop them. If they are positive, you have to continue with whatever the report shows, the wherever the bugs are sensitive to. So whatever antibiotic they're sensitive to, you have to continue with that. So these are the principles, and this is new. As I told you, back to the basics is the new in neonatal sepsis. So I hope you have understood these very basic principles of neonatal sepsis, how to differentiate between early onset and late onset, what are the bugs which are responsible, and what are the principles of treatment. So if you have liked this lecture, give me a thumbs up. If you haven't subscribed to my channel, do subscribe and press the bell notification icon, so whenever I upload a new video, you're always on board with me. So have a very good day. Bye bye.